Good morning. I am Stephanie Wanza, and I am the Outreach Manager at ASFA. And we want to welcome you to our Heart Health webinar, How to Protect Your Heart. You Only Have One. And we want to thank you so much for joining us today. And we invite you to sit back and go ahead and listen to our presentation. We have Dr. Christine Lawless, who is here to present on today. Dr. Lawless is an acclaimed physician who graduated from the Loyola University um, in the Sturch School of Medicine in Maywood, Illinois. She has an MBA from the University of Notre Dame and is a certified cardiologist, and also practices internal medicine and is formally trained in sports medicine. She is a fellow at the ACC, American College of Cardiology, and ACSM, American College of Sports Medicine. She served as an academic cardiologist for 10 years in the Loyola University heart failure and heart transplant programs, and for 10 years as a team physician for U.S. figure skating world teams. So we want to, without further ado, go ahead and ask Dr. Lawless to begin our presentation. We ask that you please hold your questions until the end of the presentation. We will have a question and answer session. So thank you again for joining us. And at this time, we will have Dr. Lawless to give us our presentation. Thank you, Dr. Lawless.
Well, thank you, Stephanie. I'm so delighted to be here today. Hopefully everybody can hear me. And I'm going to talk with you about how to protect your heart. You only have one, not like kidneys or lungs. You got two of each of those, but not the heart. And it beats about 100,000 times a day. And think of your pistons on your car doing that 24 hours a day, 365 days a year. It's a pretty fantastic machine. I fell in love with cardiology as a medical student, and I've been in it ever since. Now, Stephanie gave you a little bit of my background. I've had a lot of cardiology experience. In academics, we tend to specialize in, and I specialize in heart failure pump performance of the heart. And I worked with heart transplant patients when their hearts got really bad. I also did electrophysiology, which is all about the rhythms and electrical aspects. But then I was a skater. I was asked to be a team doctor for U.S. figure skating. And I'm like, I do heart transplants. Does that sound like sports medicine? So actually, they said, you're smart, you can learn. So I did learn sports medicine. Then I put the two together, and I founded sports cardiology at the American College of Cardiology. And you're going to hear a little bit of this. Sports cardiology ties in very nicely to preventive cardiology, which is really what we're talking about today. We're trying to protect our hearts. And now I've been for 4.5 years at Aetna CVS as a medical director in the Great Lakes region, and I do many of their cardiology consultations as well. So let's focus in on heart disease here. It is the leading cause of death for men, women, and people of most racial and ethnic groups in the United States. One person will die every 34 seconds in the USA from heart disease. And roughly 700,000 people in the US died in 2020 from heart disease. That's 1 in every 5 deaths. It costs us a fortune every year to take care of heart disease. Now, I just want to point out, because we look very carefully at CVS at differences between ethnic groups and gender and young people versus older people. And there's not one size fits all. And we're seeing that in this data here. If we look at heart disease according to ethnicity and gender, we'll find, for instance, let's look at the Asian people here. All right, these are all is about, again, the 1 out of 5, 18.9% of the deaths are due to heart disease. Males have a slightly higher incidence than the females, which are shown in like the dark pink here. So it's just something to keep in mind that not one size fits all on this heart disease, and certain disease types are more prevalent in certain groups. Now, the most common disease of all, there's a lot of heart diseases, which I'm going to explain in a minute. Coronary artery disease, the blockage in the arteries shown here, though, that is the most common form. And of those 700,000 deaths I mentioned, about half of them, 50%, are due specifically to this disease, coronary artery disease. The lifetime risk of getting this in men after 40 years of age is 49% in men and 32% in women. It's still the number one cause of death in both groups. And here's the thing, it's not an old person's disease. You can start to get blockages at a very young age. In fact, there was some very elegant work done in people who were in the military who died during wars. And when they did autopsies on them, they found 7.2% of them already had coronary artery disease. Why? Because it starts at a very young age, increases in prevalence with age, such that really by the age of 65 or so, that's where you're going to get your 50% of men and 32% of women are going to have it. A heart attack occurs every 40 seconds. About 805,000 people. These are not deaths now. These are people having heart attacks. About close to 1 million have a heart attack every year. And this is something that the doctors have to worry about. 1 out of 5 heart attacks are silent. The patient has absolutely no chest pain, nothing. So this is what a heart attack looks like. You get this blockage in the arteries. Here the blockage is in the artery coming down the front wall. And if that artery totally closes off from a blood clot, then you're not going to get any blood supply to that muscle, and the heart is not going to function properly. There's other forms of heart disease, which I'll talk about in a minute. There's valvular disease, muscular disease, aortic disease, and electrical disease. And we'll talk about all those in a second, just briefly. Now, how do we know as doctors that you've got this coronary disease? Well, generally people will get a symptom, like when they're walking or exercising, they'll get a chest pain. And we do some sort of imaging or stress testing. In this particular case, in panel A, you see dye coming through the right coronary artery, and you'll see that there's a blockage there right by that white arrow. The flow through that artery is impaired. And that's what this red is showing. Blue is normal, red is abnormal. And so the fractional flow reserve is abnormal. And they do the catheterization and they define that lesion a little bit better, and they put a stent in it. That's usually how we fix these things. But there's, as I said, coronary artery disease is just one of the problems. There are other problems as well. Atrial fibrillation is a huge healthcare burden. And atrial fib is a rhythm problem. And rhythm problems are common, very, very common. People feel them as palpitations or irregular heart rhythms. Normal heartbeats come from the upper chambers and go down to the lower chambers, and you see a nice, organized, regular rhythm on the EKG. The atrial fibrillation, the upper chambers are going at 400 a minute, and they go down to the ventricle, sometimes at a rate of 150 to 200 a minute, and the patient feels this. They could get short of breath, chest pain, they could black out. And here you see that the rhythm's very irregular on that EKG right below that heart that's fibrillating. The problem with it, it's going up in incidence from 6 million. It's going to double by the year 2030 to 12 million. That's because the population is aging and the incidence of this goes up with age. Now, when you have atrial fib, and probably many of you know people in your families or have it yourself that have atrial fib, there is an increased risk of death, heart failure, stroke. This is the big one we worry about, stroke. And of course, going into the hospital. Another common problem are heart muscle problems. On the right-hand side here, we see a heart that's kind of big and not pumping well. And on the other side, we see a heart that's thick and it's stiff. The blood can't get in. Either one results in not enough blood going out into the aorta and getting to the body. And so this is a failing heart or a cardiomyopathy. Finally, there are valve problems, and this is just one of them, showing the mitral valve. There's mitral valve stenosis, where the valve is too tight. It gets thick and the blood can't cross from the left atrium down into the left ventricle. Then there's a valve that could be insufficient or regurgitating, and that's the blood's trying to go this way out through the aorta, but this valve doesn't close all the way, and some of it's going back into the atria. Either one is a problem. And some of you, again, may have these things because they're quite common. Now, we're going to go back to the coronary disease. And I will tell you that everything we do for coronary artery disease is good for all the forms of heart disease. Okay, so say you don't have coronary disease, but you got atrial fib or you got valve disease. All these things I'm going to recommend are good for all those problems as well. Now, there's things that we can control, and there's things we can't control when it comes to modifying. And so let's look at the things you have no control over. You have no control over your family history or genetics. There's 3,000 genes that cause this blockage, and there's not a lot we can do until we figure out how to fix the genes. It comes with advancing age. Ethnicities like the Black people and the white people have a higher incidence than the Hispanics. And then, of course, males and females differ, with the males getting it a little bit earlier in life and females getting it later. There's some diseases that have a risk for coronary disease, including all the ones listed here: kidney disease, gestational diabetes, etc. Then we've got our modifiable risk factors, and those are the ones that you have control over. Smoking, high blood pressure, diabetes, hyperlipidemia, overweight, sedentary lifestyle, stress. All these conditions have been shown to increase the incidence of the blockage in the arteries. Now I'm going to show you what we can do for all of these things. And some of these you're going to be doing on your own. Like nobody can help you stop smoking. You've got to do it. And then you've got to take care of your weight. You've got to exercise and manage your stress. But your doctor is going to help you with these three here: blood pressure, diabetes, and hyperlipidemia. So what can be done? This is the good stuff. Well, first of all, stop smoking, and counseling helps, support groups help. There's treatments now in the form of medication, but keep in mind that sometimes it takes multiple attempts to actually stop smoking. If you have a spouse that's also smoking, it helps if you try to quit together and be a buddy to one another and try to help each other. Hypertension is high blood pressure. And the thing about this is to go to your doctor once a year, get your blood pressure measured. And there's excellent treatments for it besides medication. Weight loss is superb for blood pressure control. And some people find, if they weighed 200 pounds and they lose 30 or 40 pounds, they'll find that, oh my gosh, they don't need blood pressure medications anymore because their blood pressure became normal. DASH diets are low in sodium, high in potassium, and high in calcium, and these are great. They've been shown scientifically to help high blood pressure. Alcohol is a terrible thing for blood pressure. I've had patients that they stop the alcohol, the blood pressure problem goes away. You can use relaxation techniques, exercise independent of weight loss. Exercise itself is a great treatment for blood pressure. And then medications. Many of you are probably on these medications, but the beta blockers like atenolol, metoprolol have been found not to be the best because they've got some problems. Like they don't seem to treat stroke as well as other medications. So if you're on a beta blocker just for hypertension, try to talk with your doctor about that and see if this happened to my brother. He told me he was on a beta blocker for blood pressure, and he says, I don't feel good on it, and I'm not sure it's the best. So I fixed him up with one of my friends, and he's going to see him in March. And I said, make sure that you're on the best medications in 2023. Diabetes, there's lots can be done for diabetes. And again, weight loss or bariatric surgery really helps diabetes. In fact, in some folks who had bariatric surgery, the diabetes completely went away. Diets for diabetics should be low in starches, low in carbs, or if you're going to have carbs, have a whole grain, what we call the good carbs, low glycemic index carbs. And then have good fats, they're listed right here, and then lots of vegetables. Fruits and vegetables are recommended 5 servings a day by the American Heart Association. Great drugs for diabetes now. And I just want to mention that you may hear some of these newer ones, semaglutides like Ozempic or Wegovy, and they will cause, they're started for diabetes, but then they became a weight loss drug. And more about that in a second. Hyperlipidemia, that's high cholesterol. Diets are kind of controversial, just specifically to treat the hyperlipidemia. So you've got to really combine it if you have a significant problem. And it's really your doctor. You got to work with your doctor on this. Probably your doctor will combine the diet with a statin and or fish oils. Fish oils are used specifically for the high triglycerides. And then there's other fancier medications if you fail the statins. And statins are typically, you'll hear them like rosuvastatin or Crestor. They usually have the statin at the end of the name or core in their name. So there's lots of people with high lipids and they get treated very well by these medications. Obesity, one of America's biggest problems, I hate to say it. About 40% of our population, almost half, are overweight or obese. Now, what can you do about it? It's, I know there's some people that have tried so hard to lose weight and they don't seem to be able to. It's complex because there's basically too much going in than what's being expended with exercise and with that activity. So what I personally do for my patients is I start by trying to eliminate calories from drinks. I ask them, do you like lemonade? Do you like orange juice? Do you like Coca-Cola that is regular Coke, Coke or Pepsi, and not the diet kind? And so that's like one place to start, and substitute it, get water. You know, nice flavored water is kind of really nice way to substitute out. Exercise, and sometimes I took care of people that weighed 400, 500 pounds. And think about it, your heart is trying to get blood supply to 300 pounds, okay? And say that a normal person has about 5 liters of blood going around, say if you weigh 150 pounds. But if that heart has to get blood to 300 pounds, it's got to put out 10 liters. So it's working overtime. It's got to put out twice as much blood. So obesity is really bad for the heart. Now, aside from diet, exercise is a good adjunct for weight loss. And I would tell my patients, you don't have to join a gym. For the ones that weight a lot and they'd be on the couch all day, I'd say, you have to go up and go to the bathroom. So why don't you, when you get off the couch, walk around the living room a couple of times and then go to the bathroom. And when you come back, walk around the living room again. You'll get 5-10 minutes of exercise. And they would always tell me, yeah, you know what? I can do that, even though I'm a little short of breath, but I can do that. So the point is just move. The studies that were done showing the protective effect of exercise were done by measuring activity levels. And basically, the more you did, like construction workers or people who were cleaning houses, people who were exercising, obviously, but it doesn't have to be like a fancy gym that you go to. I have nothing against gyms, but basically find something you like to do and do it. Medications, we got, as I said earlier, some great medications for obesity, and these semaglutides have kind of revolutionized things. People will lose about maybe 30 pounds on that, on those medications. There's been such a demand for the medications that the diabetics can't get the ones they need for their diabetes. So the company is now responding to that and making a lot more medication. Bariatric surgery, new guidelines are out that are more aggressive. And I've personally heard of a lot of good success stories, but you've got to combine all these things with a good diet and managing the intake. One thing that's not on that obesity slide that I'd like to mention quickly is mindfulness. And actually, this worked for me. I was talking to a friend of mine, and she said she wanted to work on her weight. And I said, I do too. And I said, let's try this mindfulness. And I really when I was a cardiologist in the hospital, I was running around all over the day, all day, from the laboratory to my desk to seeing patients in the office. And I just grabbed food whenever I could. I wasn't thinking about what was going in my body. And then the last 5 years, I've had a chance to really think about what I'm doing. And so when I am hungry and I've got the choice in my cupboard between potato chips, apples, and pears, and I look at the potato chip and I say, do I want that potato chip? Why do I want it? And what's my body telling me it wants? This is all mindfulness. And then I look at the pear and I say, gosh, I love pears. My body really likes pears and it's so much better for me. So I make the choice, but it involved me having to slow down and really think, and it worked. I lost a bunch of weight with that. So anyway, we'll move on to activity here. Any activity is better than no activity. Even a standing desk can make a difference. Some people put little foot pedals under their desk and have their feet moving all day. Your goal is to get 30 to 60 minutes of activity daily, 150 minutes a week. Could be moderate aerobic, could be more vigorous, and that's recommended 75 minutes a week of vigorous, like running. And then I personally recommend this to everybody. Make sure you're getting all 4 types of exercise. Aerobic is just one of them that's very protective for the heart. But you got to worry about your bone health, your mental health, your strength, your balance, because as you get older, there's a tendency to fall and you end up with a hip fracture. So the list includes aerobic, strength training, balance training, and stretching, like through yoga or stretching exercises. So there's a lot to the whole exercise component. And then for stress and isolation, relaxation techniques, exercise, of course, make time to see your family and your friends, stay off the smartphone, go and visit them instead. Oh, and get plenty of sleep, which a lot of people do not. And this is really good for things like stress. Diet, we talked a lot, but I want to mention specific things about diet that we haven't covered yet. Meat and eggs may not be as bad as what we previously thought. I personally allow myself one decent red meat per week, like a steak, okay? And eggs, same thing. I give myself at least one serving of eggs, scrambled eggs on Saturday morning. And then the next thing, Mediterranean diet, it has its name because it came from people who live around the Mediterranean, like in Italy and Greece. And they showed that when they were on this diet, they had a decreased incidence of heart disease. And so there's a lot of really good data on this. And it basically is low glycemic index, whole grains, lots of vegetables, olive oil, and protein in the form of fish. Small amounts of alcohol. And here's my favorite. What about my beloved coffee? I personally have to have my coffee every morning. And so the studies now, we used to think that coffee made heart disease worse, but now that it's been studied very rigorously, it's been shown that it actually can be protective. It can reduce the incidence of heart disease by about 10%. And the amount that did this was 2 to 3 cups per day. So I allow myself 2 cups of caffeinated coffee per day. Now, if I have hypertension or atrial fibrillation, it's not going to make these things worse in the sense of increase your mortality rate. But you may notice as an individual patient, oh, my atrial fib gets worse when I have a lot of caffeine. Well, that's something to talk with your doctor about, because if it's making it worse, then that's the time to cut back. And that's true for anything that you're ingesting. If it makes the condition worse, don't do it. American Heart has kind of, I like this little cartoon. I think you're going to get a copy of this slide deck, and it's kind of summarized everything that I've just shown you and calls it Life's Essential 8. And it's got, the diet, the exercise, checking your blood pressure, your weight, your lipids. This is your blood sugar, and no smoking, getting plenty of sleep. So it's all there on one slide, and I really love it for that reason. Now, I want to conclude the last 5 minutes with the Demar Hamlin case. You've all heard about him, I'm sure, unless there's somebody in the far reaches of the world that may not have heard about this case. And the thing about Demar is he's a professional football player. And sometimes no matter what you do for your heart, you could still have a serious heart problem. He's 24 years old. I'll tell you the story quickly. He plays safety, which is a defensive position. He started at University of Pittsburgh, and then he went to the professionals with the Buffalo Bills in the NFL. Now, I'm saying that because both the NCAA and the NFL have extensive cardiac screening programs. They do EKGs at the NCAA level because they've got 500,000 athletes, and that's too many to do echoes as well. But at NFL Combine, they do EKG and an echocardiogram, bouncing sound waves off the heart. And so he had that. And so his heart checked out and was felt to be fine to play in the big leagues. Now, what happened on January 2nd, and he was tackling this other fella in the dark shirt. And I've watched the video myself about 10 times. I could see the man with the dark shirt. I could see his right shoulder going right into Demar's chest. It wasn't a heavy blow by any means. And then because they're in battle, right? On the football field, they're in battle. So he's got a lot of adrenaline. So even though he was in a cardiac arrest, he actually stood up and took a few steps. Then he collapsed to the ground and became unresponsive. And he had no pulse and they couldn't wake him up. CPR, thankfully, was started by the sideline medical personnel. And the sequence when you're doing CPR, get help, call 911, get the AED, then start your CPR. And hopefully the paramedics, EMTs will be there in a couple of minutes. On the sidelines, they made it a rule in 2007 to put AEDs on the sidelines of all these major sporting events. And when they did that, if somebody fibrillated, had cardiac arrest, it's very rare to happen during these games. But when it happens, if you get that AED there within the first 2 minutes, you're going to end up with a 60% chance of defibrillating that patient and getting that person back. And that's exactly what happened to Demar. They applied the paddles, the AED, they did the CPR, and they preserved his brain, and they brought him back to life with the AED. If he were back, those of you old enough to remember the Hank Gathers case in the early 90s, they had no defibrillator there. The defibrillator was like a half hour away underneath the stadium. And nobody recognized that it was a cardiac arrest. His mother came down from the stands and started doing CPR on him. And it's a heartbreaking video to watch. But we've come a long way. That's my point. We really have come a long way. And what did he actually have? He probably had a condition called Komoshocortis, which I'll show you what it is in a second. It was due to that blow to the chest. He could still, even though he had all of the screening, he could still have an underlying cardiomyopathy, an anomalous coronary artery infection of the heart. Or he could have been using drugs, even though they test them, but he doesn't seem like the type. But that's still in our, what we call our differential diagnosis. And what Komoshocortis is, now it's rare in football. In this case, it seemed to be because that opposing player's body part hit Demar's chest. But most of the time, this will happen in hockey, lacrosse, baseball, or in martial arts, taekwondo, things like that. Baseball, it was pretty prevalent, and it mainly happens in teenagers because the balls are going faster at that age, and yet the chest is still quite pliable. And when that ball hits the chest, hits the heart in its very vulnerable period. And research has shown it's got to be within a 20 millisecond window. These are thousandths of a second, 20 milliseconds. And so it was just like, you know, a very strange phenomena that happened in Demar. And when it happens on the upstroke of the T wave here, the person goes into ventricular fibrillation. That's a cardiac arrest, a very disorganized rhythm. Now, this is my last section. The big question is, can Demar go back to playing? Well, he hasn't said what his heart disease is. His doctors haven't said. I have a feeling they are still waiting for something like genetic testing or something to make sure he doesn't have something really bad. And if it was the Komoshocortis, people can go back to playing after they've had that condition. And there was just recently a soccer player that did it. Demar, there's this beautiful mural that is somewhere in Buffalo Bills territory, and I think is quite beautiful. And here, this is actually Demar here, and he's got one of his jackets on, and he owns a fashion merchandising company called Chasing Millions. So if he can't go back to football, it looks like he's got something to fall back on here. He's got his own company, and he even made a shirt that said, "Did we win?" which was the first thing he said when he woke up from his cardiac arrest. And so he's also, by the way, he's partnering with the American Heart Association to promote CPR and AEDs. And CPR is a very, very simple thing these days. You just take your hands, the lower sternum, at a rate of 100 to 110 beats per minute. I tell people, use the tune "Staying Alive" by the Bee Gees. Staying alive, staying alive. And that's 100 beats per minute. Okay. So it's simple. We are the first responders, the general public. When there's a cardiac arrest, you have to call for the paramedics, EMTs, the firefighters. We're the ones that are going to be there the first 2 minutes. And so if you just take your hands, and you don't have to worry about doing mouth to mouth anymore for the first 2 minutes at least, just start doing the CPR and then let the pros take over when they come. But 100, 110 beats per minute, staying alive, lower end of the sternum, compressed at 1.5 inches. So I want to thank you for letting me be here today. I really, really enjoyed it. And I hope maybe you learned a little bit about how to protect your heart. And I want to wish everybody a happy Heart Month. The month of February is always Heart Month. So I'm going to hand it back to Stephanie and see if there's maybe questions. Do you want me to go on mute right now, Stephanie, or stay on?
Yes, just for one moment. I did want to give some information about resources. Thank you so much, Dr. Lawless, for this awesome presentation, which was so informative, that gave us information about diet, exercise, about mindfulness, and about really committing to making sure that our heart health is optimal. I want to thank you so much for everything that you have shared with us on today. And I want to just give some information about resources to help with our heart health. We have a remote hypertension monitoring program here at ASFA, also lifestyle and condition health coaching, which is a holistic approach to help you and your dependents achieve your best health, and digital coach program, which is for weight management, smoking cessation, stress, nutrition, physical activity, cholesterol management, blood pressure, depression management, and sleep improvement. So here is the link at the bottom if you're interested in any of these programs, and we invite you to go ahead and make sure that your heart health is just optimal, and make sure that you take care of yourself as we look at Heart Health Month. So at this time, we do have a few questions that I wanted to go ahead and make sure we address. Our audience had some questions here. So I'm going to ask Allie if she can assist us with these questions, and Dr. Lawless will go ahead and answer. We could just read these questions off and go ahead and have Dr. Lawless and Allie to assist us with that, with our question and answer session. So I'll go ahead and read the first question. Maybe Allie can get the next one. And the first one is, I'm 61. Is there a preventive test that I can take to know how my heart is so I can catch something early? And so that's for Dr. Lawless.
That's an excellent question. Thank you so much. The main thing, I'm not sure what age bracket you're in, but the main thing is to see your primary care physician or nurse practitioner once a year. And when you're at that meeting with that provider, they will ask you about all your risk factors. And they will also ask you if you have any symptoms. And then if either you've got a lot of risk factors or you have a lot of symptoms, they will order an appropriate test. Now, some people who have no symptoms whatsoever, they like to get something called a calcium score, which is done with a CT scan, and they like to get that done on their heart. The problem is most insurance companies on an asymptomatic patient will not pay for it. But I heard of one the other day that only cost $49 in Wisconsin. And so you can get them done inexpensively. Now, does that show you if you have blockage? Not really. What it shows you if you've got calcium in the walls of the artery, which is an indication that you've got early heart disease. And then the doctor might choose to put you on a statin medication or other medications to treat that early coronary disease. So those are some of the things. But I think that seeing your doctor, nurse practitioner on an annual basis is probably the very most important thing that you can do for your health. Okay.
Thank you so much, Dr. Lawless. And our next question is, since you mentioned that heart attacks can be silent, how would one know if they had one?
Oh, I love these questions. Very, very good. This is something I didn't include because I want to make sure I stayed on time. But first of all, I want to talk about heart attack symptoms. And symptoms from the heart can be anything from the waist up. Now, if you get, this is a typical one for a man, they get chest pain going down the left arm associated with maybe dizziness, sweating, sometimes vomiting. Jaw pain is another area that it goes to. And that, don't stay at home with that, okay? You got to go straight to the hospital emergency department with that symptom. That is signs of a heart attack. Now, in women, the symptoms are a little bit different. Yes, they can still get chest pain, but more often they get back pain and they also get nausea and vomiting a lot more. And we're having a presentation tomorrow on women and heart disease at our company. And one of the ladies who had a heart attack is going to be presenting her whole story. And she had the back pain, nausea, vomiting, sweating, and she stayed at home. And it took her 2 weeks to finally go and see a doctor. And she, in the meantime, had lost a lot of heart muscle. But not to worry, she's doing all the right things now and she survived all that. But I'm so grateful she's going to hear her story. Now, what if you don't feel anything? Well, again, the most important thing you can do is go see the doctor at least once a year, and they will check you for these silent things. But mainly, if you have any symptom whatsoever, to go and let the professionals figure out what the problem is, okay? I tell people, don't be making a diagnosis on yourself, okay? And don't start like cruising the internet to look at the symptoms and see. When you come to the hospital with a heart attack, we have about 1 hour to get the blood flow back into the heart. And if we get it in within that first 60 minutes, you're going to do very well. You're going to recover completely from that heart attack. So I have to admit, the asymptomatic heart attacks are still problematic for all of the doctors because the person doesn't even feel it. And that's really how we know. So the only way to know is go and get checked out once a year. And sometimes the doctor, when you reach a certain age, they might do a stress test, especially if you have risk factors. They may do a CT angiogram scan. So I hope that answers it for you.
Okay, we have another one. Dr. Lawless, if one is far from healthcare on travel, would you recommend always having a low-dose aspirin as a quick intervention for a heart attack?
Well, you can use the aspirin, but it's no substitute for getting to the hospital and getting the artery opened. Okay. And that's about all I'm going to say about that one.
Okay. Another one is, what about coffee intake for pregnant people? Is there any new data on that?
Ooh, I don't claim to be an expert on pregnancy. That would be an obstetrician. What I could do is look it up real quick to see what the obstetrics community is saying about coffee and pregnancy, and get back. I don't know, Stephanie, if there's a way to get back to somebody about this, but I'd be happy to look it up and provide the information.
Yeah, we should be able to get back to them.
Yes, we should be.
Yeah. What about coffee? What about coffee just for, what is a normal coffee intake just for someone who's not pregnant? Can you give recommendations on that?
That I would go with what these studies were showing. And the studies showed 2 to 3 cups a day seemed to be cardioprotective and did not increase your mortality. In fact, it lowered the mortality. So that's exactly where I just had my second cup, and I'll have another one this afternoon. So 2 to 3 cups a day.
Another question, how do we know when to ask our doctor for heart diagnostic tests over and above the blood pressure and EKGs?
Oh, some important times to ask is when you have a positive family history. And, I've seen patients where somebody in their family had a heart attack at the age of 35, and they didn't have high cholesterol and they didn't smoke. So that seems to be totally related to genetics. And that the doctor may want to start looking for heart disease. For instance, what if you're 40 years old and you had that family history? The doctor may be more aggressive in looking for disease. They might do a stress test. They might do the CT angio with the fractional flow reserve. Sometimes you have to fight your insurance companies a little to get some of these things paid for. But that I can't stress enough the importance of going to see your doctor once a year, because they've got all these things on their mind, what they want to check in you, and heart health is one of them. And if you came to me, for instance, and had this history of heart disease at the age of 35, I definitely would keep a closer eye on you, test for more things, get those lipids down into a really aggressive range, aggressively controlled range. So I hope that answers it for you.
Okay. What is the difference between AFib and atrial flutter?
Okay, they're very similar, all right? Atrial fib, if you were able to look at the heart that's fibrillating, I'm going to try to do this with my hand. It would look like this. Atrial flutter, you can actually see the flutter waves on the EKG, and they're more like this. They're more coordinated. The atrial flutter goes about 300 a minute, and the atrial fibrillation is over 400 a minute. Now, from a practical point of view, they both can cause stroke. They both are treated the same way with medications, control of the heart rate, and anticoagulation or blood thinners. So from a practical point of view, they're treated the same, but they look very different on the EKG.
Okay, another question. Are weight loss medications like Wegovy safe?
Safe? Was that the last word?
Yes, safe.
Yeah, okay. Safe. Well, as far as we know, they are. But if you've seen the commercials on TV, you see that there's a lot of things about endocrine disorders and kidney disease. So there's certain instances where you cannot take those drugs. And then the other thing to be aware of, they have side effects. And one of the worst ones with those drugs is nausea and vomiting. And that's something to be aware of, because now the pharmacists and doctors, they've got tricks on how to manage the nausea and vomiting. But for some people, it's so awful that they have to stop the drug. So generally safe, but that with a little asterisk. Okay.
Okay. Please define coffee. Is that black, no sugar or cream, and like things like Starbucks variety? Or is it just, are you just referencing the caffeine, Dr. Lawless, the caffeine intake?
Yes. In these studies that were done, they actually broke out all the different types, and they specifically focused on the caffeinated coffee. But there are some studies where they had 300,000 people and they could divide it out. And no matter which way you look at it, coffee was not a problem, which I find that very refreshing.
Yes. Another question. Thank you very much, Dr. Lawless. Is baby aspirin enough for a person who has hypertension and diabetes and a family history of strokes?
I'm thinking because, we have something we call a CHAD score, and I'm not able to calculate that based on what I was given. So I would say this is something to talk over with your doc, because they will have have all the comprehensive information to figure out if you need more than just the aspirin. Okay.
Okay, here's another question. What do you suggest if we want to get off a blood pressure medication, like a 10 milligram of enalapril daily, and don't think we need it? It tests low at home, but in the normal range at the doctor's office.
All right, let me make sure I understand this. They're asking if they can go off the medication because the blood pressure is low at home, but it's higher in the doctor's office, but still in the normal range on the medication. Did I hear that right?
Yes.
Okay. So this is, again, something to talk over with the doctor, because they've got all your blood pressure measurements. You can bring your blood pressure measurements to the doctor and go over it. There is something we used to call it white coat hypertension, where you go to the doctor's office and there's a certain amount of anxiety and it would make the blood pressure go up in the doctor's office. Whether or not that's in play here, it doesn't sound like it's a classic example. But if you've done other things, like you've started an exercise program or you've got your weight down by like 20 pounds, I think it's well worth talking to the doctor about going off the medication. The worst can happen is your blood pressure goes back up and you have to go back on the medication. So I think it's something to talk with them about for sure.
Thank you. Another question is, what does it mean if I have a resting pulse of around 45 to 50 beats per minute most of the time, but pre-hypertension 135/90 on average?
Okay, the pulse I'm not concerned about. That depending on what your activity level is, and especially if you're not having any symptoms of dizziness, that could be a totally normal pulse or heart rate. The blood pressure is a little more problematic because, we're getting more aggressive with treating hypertension. And this again is something where you want to collect, if you've got a home blood pressure cuff, collect a lot of different measurements and then bring that to the doctor and then, get several measurements at the doctor's office. If you don't have a cuff, I think they'll do blood pressures. There's places where, like at the Walmart or at the fire station, where you can ask them to do your blood pressure. But I worry a little bit about that blood pressure and whether or not you need to go on a medication for it.
Thank you for that answer. What was the name of the calcium test?
Oh, it's called CT, because that's the technique, CAT scan, CT calcium score.
Okay, thank you. And someone was asking, what is the surgery that can stop or help diabetes? And that is the gastric bypass, right, Dr. Lawless, that you were in reference to, that sometimes can help with diabetes, the weight loss?
Yes. There's several different forms of bariatric surgery, and the bariatric surgery is highly effective. There's gastric banding that bypasses one of them, and again, I think if you're sincere, you get the surgery done, and then you're sincere about doing your diet and exercise and all the other good things you have to do, I think you can get a very good result from bariatric surgery. I was given a talk yesterday, and one lady put in the chat, she lost 100 pounds 10 years ago after her bariatric surgery and has not gained 1 pound back. So when she had diabetes, it completely went away.
Yeah, and I will tell you that is something that the Foreign Service Benefit Plan covers. Just certain criteria has to be met. So, that is, there's information in the official plan brochure on that. So, so another question is, I'm 65 and I've been taking an ACE inhibitor for 5 years for hypertension. I recently experienced about a very high elevated blood pressure. So my primary care physician added HCTX to my daily medication. What is in the diuretic that reduces blood pressure physiologically?
Basically, it eliminates water and salt through the kidney. And salt is super, super important for hypertension. And so that's why the DASH diet works. So that's basically how a diuretic works as well.
Okay. So let me see. The next question is, what is the earliest someone with no symptoms but a genetic heart disease background should take a cardiac Doppler test or any other test?
Can you repeat that one more time?
What is
Stephanie,
the earliest
that?
someone? Yeah, can you hear me?
I can hear you.
What
now.
is the earliest someone with no symptoms but a genetic heart disease background should take a cardio Doppler test or any other cardiovascular test?
Okay, so this is when you're saying Doppler, I'm thinking bouncing sound waves off the heart and looking at the chambers. And it sounded like the person had a history of congenital heart disease. In general, patients are followed pretty much every year, sometimes by their pediatric cardiologists until well into adulthood. And they generally will repeat those echoes periodically to see what's happening with the hole in the heart or the PDA or whatever other form of congenital heart disease. We didn't touch very much. We didn't touch at all on congenital heart disease, but there are heart diseases where the heart doesn't form properly in the fetus, and it's supposed to like divide into the 4 chambers, and sometimes it doesn't do that, and there's like holes in the heart where there shouldn't be, and other forms of heart disease. So, but somebody who has that is generally followed by a cardiologist quite often, usually annually. So I would leave it up to whichever doctor is following you for that particular problem. Ask them that question: do you need to have another echo Doppler? And see what they say.
Okay, thank you. Do night sweats have any correlation with heart health?
Not that I know of.
Okay. How old is too old to have an angiogram and angioplasty?
Oh, I don't think we have any age limits these days. There's articles written in the literature of people in their 90s having these things done. Used to be you'd see an article 10, 20 years ago, people in their 80s. Then we started to see people in their 90s. Now some people are 100 years old and having it. It's just got to do with what sort of shape you're in and what your goals are in life. And yeah, and that's all discussed very quickly when the person comes in with a heart attack. And while the cath lab is being prepared, the doctor's there talking with the family and the patient, like, okay, this is what we want to do. This is what we do for everybody for this condition. And do you want to have it done? And these are the complication rates, and this is what to expect afterward. And then leave it up to the patient. But yeah, there's been plenty of procedures done in people in their 90s and close to 100.
Okay. What is your opinion about Bupropion and weight loss?
Any of the weight loss drugs, they are approved for these things, and they're approved because the research showed that there was efficacy. So with that particular drug, I think people lose like maybe 10, 20 pounds. But again, it wouldn't have been approved by the FDA unless there was some indication that it actually worked. So all that said, again, if you weigh 300 pounds, you're not going to get down to 150 from taking that medication. So
okay.
I don't think it's the best one, to be honest with you. I think there's some better ones out there, especially these newer ones we mentioned already. Now, Stephanie, I have to tell you, I've got 2 minutes left because at 11 o'clock, I've got another meeting, another one of these presentations. So I wondered how we're doing on the questions.
Yes, we have a few more questions. Maybe we can take maybe one more question, and then we know that you have to go. So maybe one more question, and we can move forward.
Yeah. Can you repeat the amount of eggs and red meat you'd eat weekly or daily?
Some people really, really like red meat and eggs. And I'm of the opinion everything in moderation, alcohol, coffee, is not going to hurt you. The same thing with red meat and eggs. And the research that's been done recently has been much more favorable towards both the red meat and the eggs. What I do personally is I allow myself 2 scrambled eggs once a week. Okay. Some people may want that more. Like some people take eggs every day in the form of like hard-boiled eggs. Other people, they like red meat. And for me, I allow myself like 1 decent red meat per week, like a steak. The rest of the time, I am doing fish and salads. Sorry for the noise in the background.
Okay.
All right.
Thank you.
That is. the end of our questions. And I didn't know, Stephanie, if we could get some of these other questions. And when we send that presentation out, we could get Dr. Lawless to go over some of these questions.
Yes, we can go ahead and forward those questions to Dr. Lawless and see if she can answer them at a later time. I want to thank her so much for answering all of these questions and for this awesome presentation on today. This presentation is being recorded, so you can go back and listen to all of the information that was shared on today. I do want to thank everyone for joining us on this afternoon, and we want to encourage you to join us monthly as we have our health webinars, our health educational webinars here at ASFA. Thank you so much and have a great day.
Thanks. Bye-bye.